Thank you, Dr. Kim. Thank you, Dr. Chairman, for my introduction. This is my privilege to speak at the Winter Quack this year. My topic today is unmet clinical needs in post-PCI antithrombotics and introduction of RCT in progress. Antithrombotic treatment is determined based on patient characteristics, clinical presentation, comorbidities, concurrent medication, and procedural factors. The combination, initiation, and the duration of the therapy are tailored by carefully considering the balance between ischemic and bleeding risk. In the early era, the focus was on preventing early cardiovascular events, including stent thrombosis, and ensuring the effective secondary prevention of ischemic outcomes. I still remember that when I was the first-year resident, the most important medication when I present to the attending doctors is that make sure that the aspirin and clopidogrel was properly administered to the patient undergoing the PCI. And this trend reached its peak with the Triton TIMI-38 and the Plato trials. In these studies, the potent P12 inhibitors, ticagrelor and the prasugrel, significantly reduced major cardiovascular events, but however, an excess of major bleeding events was observed throughout the maintenance period. And ironically, the publication of these two trials, signals the enhanced recognition of the impact of the bleeding on clinical outcome after PCI. And the more and more data accumulated regarding the impact of the bleeding overall prognosis. According to previous analysis, the impact of the major bleeding on mortality is equivalent to MI, and only major bleeding is even more fatal than MI. The why bleeding matters? The spontaneous bleeding consistently shows that spontaneous bleeding after PCI was comparable to MI in terms of long-term mortality, and this trade-off between efficacy and the safety bolsters the argument for personalizing antiplatelet therapy after PCI. The risk of bleeding is determined by age, comorbidities, such as renal or the liver failure, anemia or thrombocytopenia, previous stroke or ICH, or history of bleeding, iatrogenic factors such as medications or surgery. The patient with HBR is expected to have more than 4% BARC 3 or 5 bleeding annually, or ICH risk of more than 1%. Consequently, the balancing the ischemic and bleeding risk and finding the sweet spot is essential in antiplatelet therapy after PCI. Especially, the E-stage patients are known to have a more bleeding risk and the rest ischemic risk, shifting the therapeutic window toward bleeding. Consequently, managing bleeding risk is even more important in E-stage patient. Following the increased awareness of the impact of the bleeding, the clinical trials conducted to achieve a balance between ischemic and bleeding risk. And these trials explored experimental strategies at the time, such as a de-escalation of DAPT to P12 inhibitor monotherapy, and the step-down approaches to reduce the intensity of DAPT. There are three primary strategies for de-escalating antiplatelet therapy: switching, dose reduction, and the discontinuation. The switching refers to replacing a potent P12 inhibitors with a less potent one. The dose reduction strategy reduces the dose of a potent P12 inhibitor, while discontinuation refers to stopping either aspirin or the P12 inhibitors. The global leaders, Twilight, TICO, and TPAS trials were representative studies that employed the de-escalation through discontinuation and continuing with potent P2I inhibitor monotherapy. Notably, all these trials utilized ticagrelor as the potent P2I inhibitor, and I'm going to briefly go through some of these trials later. And the STOP-DAP2, STOP-DAP-ACS, and Smart Choice trials were representative studies that utilized de-escalation through discontinuation and continuing primarily with clopidogrel. STOP-DAP2 demonstrated that the non-inferiority of clopidogrel monotherapy in terms of net adverse events. However, the STOP-DAP-ACS failed to confirm these findings, suggesting that the clopidogrel monotherapy initiated only after ACS may increase the ischemic risk and maybe we need more potent P2I inhibitors for this kind of patient. The Twilight, very classic and landmark trial, as previously mentioned, demonstrated that in high-risk patients transitioning to ticagrelor monotherapy after 3 months of DAPT resulted in a 40% reduction in BARC2, 3, or 5 bleeding events with no significant difference observed in MACE. And the TICO trial, in TICO trial in ACS patient, ticagrelor monotherapy after 3 months of DAPT compared with TICA-based 12 months DAPT resulted in a significant reduction in composite outcome without increasing the ischemic outcomes. And the Smart Choice trial showed that P2I12 monotherapy after 3 months is non-inferior to 12 months DAPT. And 3 months landmark analysis and PP analysis showed a consistent result. And in TPAS trial, which is a similar design, with the later ultimate DAPT trial. In this trial, in ACS patient, stopping aspirin within 1 month for ticagrelor monotherapy is both non-inferior and even superior to 12 months stopped for 1 year composite outcome of death, myocardial infarction, and stem thrombosis, stroke, and major bleeding. And in the ultimate DAPT trial in patients with ACS-treated PCI, the treatment of ticagrelor monotherapy decreased clinical relevant and the major bleeding without increasing MACE. And this trial confirms the result of the prior trials and the warrant update of the guidelines. And the next one is a de-escalation by dose reduction and the switching. And the trials presenting here, these trials serves as a representative studies of DAPT de-escalation through dose reduction or switching. They include both guided and unguided de-escalation strategies, with both approaches demonstrating non-inferiority when compared to standard DAPT. The tropical ACS trial showed that the benefit of the PFT-guided de-escalation in ACS patient in terms of NACE without increasing MACE, and there was no significant difference in bleeding and the MACE. The host RP-ACS trial is a one-of-a-kind study in that it shows the benefit of a prostate dose reduction in ACS and it shows a similar benefit in NACE. And the thalassemia trial demonstrates the benefit of the unguided de-escalation strategy, transitioning from the TICA-based DAPT to aspirin plus clopidogrel in terms of net adverse clinical events in patients with MI. Importantly, this study shows that no significant increase in MACE, and the primary endpoint was primarily driven by a reduction in BARC2 or greater bleeding, but the BARC3 or 5 bleeding also showed a significant reduction. The MAST-DAPT trial is also another landmark trial, and this trial evaluated the benefit of abbreviated DAPT in high bleeding risk patients and demonstrated that the non-inferiority of the abbreviated DAPT strategy in terms of NACE and the MACE. So with accumulating evidence supporting the benefits of DAPT de-escalation, the recent guidelines recommend the tailoring therapy based on the patient ischemic and the bleeding risk. In patients with CCS who are not at high bleeding risk, the default treated strategy involves the 6 months of death followed by the SET. But for HBR patient, DAPT can be abbreviated to 1 to 3 months, followed by aspirin or clopidogrel-based SAPT. But when aiming to reduce bleeding risk in HBR patient, DAPT can be limited to 1 to 3 months, followed by single antiplatelet therapy, and alternatively, a TICA or prospero-based DAPT regimen can be used for 1 month, followed by a combination of aspirin and clopidogrel. But there is still the gaps in evidence in the current trials. For example, first, what is the optimal time point for DAPT before de-escalation? As we have observed, several trials have proposed a various duration of DAPT prior to de-escalation. However, which of these represent the better or the best strategies? And the timing of DAPT discretion should be based on the clinical setting and individual risks. And the many reviews, the many previous trials employ the SAPT with aspirin support 3 to 6 months, and the SAPT with the P2Y12 inhibitor, the 1 to 3 months. And the de-escalation of that intensity supports 1 month or less. The host BR trials aims to evaluate the efficacy and safety of 1 month of DAPT compared to 3 months in high bleeding risk, and the 3 months of DAPT compared to the 12 months in low bleeding risk patient in terms of the POCO at 1 year. And as I know, this trial completed enrollment and analyzing the result and expected to present next year or maybe the year after next year. And the second, there is a scarcity of data on whether aspirin or the P2Y inhibitor should be preferred for long-term antiplatelet therapy. As outlined in the guidelines, the default strategy permits either aspirin or clopidogrel following DAPT. But in patients with high ischemic risk, continuation of DAPT or ticagrelor monotherapy may be employed. However, the evidence of optimal long-term antiplatelet therapy remains limited. There is only one RCT to address that the question. The holistic jam led by Dr. Hyo-soo Kim exquisitely demonstrated that the clopidogrel was a significantly reduced ischemic and bleeding risk compared to the aspirin. And the Panther meta-analysis, including ACID, CADID, CAPRI, DACAP, and holistic jam and the TCAP trial also show that the P2Y inhibitor, mostly clopidogrel, provided a significant benefit in MACE and might be preferred over aspirin. And currently, unpublished SMART Choice 3 trials compares the aspirin and clopidogrel in high risk of recurrent events after PCI after 6 to 12 months of DAPT. And as I know of again, it completed enrollment and waiting for the publication of its result. And the third, and another issue is that is a potent P2Y inhibitor monotherapy without prior DAPT possible? The concept of potent P2Y inhibitor monotherapy without the prior DAPT is supported by Twilight sub-study, and this study shows that the platelet reactivity was similar with DAPT by ex vivo thrombogenicity. And the early pilot studies, like in Optica study, SS study, and SS Japan, show that reported the promising result of a monotherapy of a potent P2Y inhibitor immediately after PCI. But this concept is mitigated by the result of the STOP-DAPT-3 trial. STOP-DAPT-3 failed to show the superiority for major bleeding and increased coronary events within 1 month after PCI. And the fourth one, and maybe the last one for my topic, is a head-to-head comparison of this de-escalation strategies. The ADEN trial compared the potent P2Y inhibitor monotherapy versus genetically guided selection of aspirin or clopidogrel in HBR patient. After DAPT with potent P2Y inhibitor, the patients are randomized to either monotherapy by potent P2Y inhibitor or aspirin clopidogrel based on genetic testing. And another trial, PRODCHIP, which is being performed by our institute, that compares the potent P2Y inhibitor monotherapy versus a de-escalation group after aspirin plus prasugrel in ACS-rich patient. It is actively enrolling the participant and expected to complete accrual around 2026. So my conclusion is that the antithrombotic treatment after PCI has evolved to pursue the balance between ischemic and the bleeding risk. And there were many unmet clinical issues, such as the duration of DAPT and timing of de-escalation, head-to-head comparison among de-escalation strategies, and the selection of antiplatelet for long-term management would advance the clinical application of antithrombotic treatment in this population. Thank you for your attention.